Good morning, everyone. I'd like to thank, first of all, the Begain family for organizing this, and it's always a pleasure to come out and share some new news about the treatment of melanoma. I'd also like to thank Dr. Pavlik for putting this together and for giving such a superb introduction, as well as Dr. Goidos. They definitely make my job easier. I'm going to talk about using the immune system to treat melanoma. This is something that we've spoken about for a while, but we really have some new exciting developments in the past few years that are definitely worthy of everyone's attention. So for anyone who wants to go to sleep, these are the big messages. This is a time of great hope for the treatment of melanoma. For the reasons that I'm going to outline and for the reasons that Dr. Maynard will outline, there are new drugs that are in clinical trials now, hopefully to be approved very soon, that have literally been the dreams of many of us in the community for a long time and are really transforming the way that we think about this disease. To just give a shout out to the organizations like Molly's Fund, there's a really crucial importance for grassroots support of patient education and research. Organizations like this are vital to our mission. And also that participation in clinical trials is so important, and the institutions represented here by all of the speakers really represent absolute excellent standards of care, pillars of the community that are running cutting-edge clinical trials, and this is very, very important to our making progress. So as you've heard about, and as Dr. Goidos really just very nicely spoke of, there are several ways to treat cancer. Surgery is certainly number one on the list of effective therapies for melanoma. This is, in fact, a surgical disease. It is responsible for curing more people with melanoma far and away than any other treatment. The other conventional ways that we think about treating cancer are with chemotherapy, or which is really a kind of a garbage can word for medicines that interfere with the way that cells divide. People think of chemotherapy as just one or two drugs that make you vomit till your hair falls out. But in fact, chemotherapy represents about 50 or more drugs. The numbers are growing every day. Some of which have those side effects, some of which don't. But it's a big word that just makes this sort of visceral response in people. And then radiation therapy, which Dr. Goidos just touched on, is used certainly to treat brain metastases and to palliate bone metastases in melanoma. And then there's this concept called immunologic therapy, trying to get the body's immune system to recognize that cancer, in this case melanoma, is something foreign, that it should be recognized and disposed of like an infection. Has been something that we've all thought was quite logical for a long time, but not very practical. And that's why it's kind of fourth on the list. But I think in the next year or so, we're going to see this thing creeping up into the top of that list for a lot of reasons. Immunologic therapy is going to be considered a mainstream type of therapy. We've all heard a lot in the news about the Provenge prostate cancer vaccine and all the positive data surrounding that. And so I think that we're going to have really important approved therapies for many cancers in the near future that are based on the immune system. But let's just review a little history of where this idea of using the immune system came from. So extra bagel for anyone who knows who this couple is. All right, no takers this early on a Saturday morning. So the dapper gentleman with the bowler hat in his hand is John D. Rockefeller Jr. And this was taken in sort of the late 1800s when he was about 16 or 17 years old. The lady sitting next to him, name was Bessie Dashiell, who was his lady friend at the time. And she actually died about a year after this picture was taken from a sarcoma on her left arm. And it was, in fact, the death of this young woman that inspired in the Rockefeller family a desire to use their fortunes for medical research. But it was also the death of this young woman that inspired her surgeon, who is the gentleman with his arms crossed in the center there, a guy by the name of William Coley. Coley was sort of the hottest bit of surgical talent at the turn of the last century. the 1800s to 1900s time point. And Coley was the one who was called on to operate on Bessie Dashiell, and he did the best that he could at the time, which was sequentially amputating greater and greater parts of her arm until she died anyway. And so he was horrified by this, and so he, along with other patients whose deaths he had witnessed, he said there's got to be a better way. And that better way, he actually theorized, was through the immune system. Now, why did he have this idea? Well, he used the only real tool of research that he had at the time. I mean, this was before the great advances in molecular biology and even cell biology. The microscope was barely invented at this time. He used the powers of his clinical observation. And he observed that patients who developed infections after they had surgery for cancer lived longer than patients who didn't have infections after their surgery for cancer. And infections after surgery were much more common, certainly 150 years ago than they are now, because we now have antibiotics, we have sterile technique, we have sterile gloves, we have all sorts of things that make surgery, a very safe thing to do, which did not exist when Coley was around. And so Coley had the very insightful thought that if someone had an infection, it turned on their immune system. And if the immune system were turned on around the same time that the cancer was being removed, that any residual cancer cells could be recognized by the immune system in the context of this sickness from the infection, and the immune system would remember what those cancer cells looked like, and the patients would stay free of cancer for longer. And Coley had this idea in 1880, and nobody actually really proved it until almost 100 years later. And in fact, he developed a therapy called Coley's toxins, named after him, obviously, which was actually in the U.S. pharmacopoeia until the 1950s. And it was a vaccine made of dead bacteria. It fell away as radiation and chemotherapy became in vogue, but he was on the right track. And just to continue the little trivia contest here, the bottom of the picture, I don't know if you can see it, says the R&C Hospital Christmas Party in 1892. The R&C Hospital is the Hospital for the Ruptured and the Crippled, which we now more politically correctly call the Hospital for Special Surgery in New York. So Coley was a real denizen of the Upper East Side of Manhattan. And this was one of Coley's patients. This is sort of the clinical data from the time, a person with a sarcoma on the neck that had been injected with this dead bacteria and went away. And this was the data. There were no CAT scans. There was no molecular testing. There was, just a very crude photograph of a man who had had a sarcoma on his neck that Coley injected with bacteria, and it went away. This picture was taken 7 years later. But again, it took a long time for us to figure out what Coley was talking about. But now we know that there is something called immunotherapy, and we divide it into two different flavors. One is called passive immunotherapy, where we, meaning the doctors, the nurses, the drugs, do the work for the patients. When we give people an injection of an antibody, drugs like Herceptin or Rituxan, which are used for breast cancer and lymphoma, those are antibodies, proteins that recognize part of cancer cells and cause the immune system to come attack it. Or immune hormones called cytokines, like interferon, that's used for melanoma, or IL-2, which I'll tell you a little bit more about, interleukin-2, which is also used for melanoma. And then there's active immunotherapy, where we ask the person's immune system to do all the hard work, like a vaccine. When you give someone a vaccine, you're injecting either dead cancer cells or a target found on cancer cells, and you're asking the patient's immune system to recognize it, make an immune response to it, and go after it. So those are the two different kinds of immunotherapy. There are 3 drugs approved for the treatment of melanoma in the United States in 2010, and I'm not proud of this. One of them, dacarbazine, was approved in the 1970s. It's a chemotherapy drug. It benefits a few people with melanoma, but for a short period of time. Interferon alpha is used to treat people after they have surgery for stage 3 melanoma. It was approved about 14 years ago. It may delay recurrence after surgery, but it doesn't cure very many people that have not otherwise been cured with surgery alone. And then there's high-dose IL-2, which was the last drug approved for melanoma about 12 years ago. And I'm going to tell you a little bit more about IL-2 right now. So IL-2 was published, if you will, in the noted scientific journal Fortune in 1985 as a cancer breakthrough. It is a growth factor for a type of immune cell called a T cell. And it was actually discovered largely through the work of investigators at the National Institutes of Health and Dr. Steve Rosenberg in the surgery branch. There really was the driving force in bringing this into the clinical arena. And the data for IL-2 is actually quite clear. If you just, I was noticing in the audience that the colors changed, so I have to make sure that, yeah, the top line there is still blue. Okay, so that top line represents the survival of people who have a complete remission after getting high-dose IL-2 for metastatic melanoma. And what you can see is that that line remains absolutely flat for 10 years or more. So there's a significant number of people who, if they have a complete disappearance of melanoma with high-dose IL-2, and they are still in remission at 2 years, they are still in remission 10 years later. And this is the hallmark of immunotherapy. It has a memory. Once the immune system has been trained to see melanoma, it doesn't forget. And so even if a cell may pop up now and again, our assumption is the immune system can get rid of it. The problem with IL-2 is, let me get my finger warmed up on the pointer here, is this number right here, the response rate. The number of people who actually have their tumor shrink from IL-2 is about 16%. So it's only a small subset of that 16% that actually have this long-term benefit. Now, we know that just turning the key is not enough to get the car moving. You need to have an accelerator pedal. And so that accelerator pedal on a T cell is a molecule called CD28. But we also know that a car that has an accelerator and no brake is in big trouble. And so the immune system has a braking mechanism called CTLA4. And CTLA4 basically starts up once the gas is hit. And its job is to make sure that the car does not speed too quickly and the person doesn't develop autoimmune disease. We know that mice that don't have CTLA4, that don't have this brake, develop autoimmune disease. They have immune cells that attack every part of their body and they die very early in life. We also know that there are some people who have a genetic mutation in CTLA4 and they are more likely to get autoimmune disease like rheumatoid arthritis or lupus. So we know that this is a very important brake that prevents our immune system from attacking normal body parts. However, we also know that if you can temporarily turn off this brake, that might be a way to get the immune system to see melanoma better. And this is just a little bit more scientific diagram showing. This is the T cell up here. It's red on my screen, but darker on yours. This is the T cell up here, and this is a cell called an antigen-presenting cell, which shows the target to the T cell. And you can see that there's this is the ignition key, okay, and this is the accelerator. And then over here, this CTLA4 is the brake. And what we're doing is we're blocking that brake from turning off the T cell. And so this is actually a CAT scan of the liver from Tom Telford, who you're going to hear from in a little while. And I actually got his permission to show this. He told me he wouldn't freak out from seeing his own liver. Tom was one of the first people who we treated with a CTLA4 blocking antibody called ipilimumab, which is now in the last stages of clinical testing for melanoma. And he was in a study where we were exploring different doses of this ipilimumab drug, and he received sort of a modest dose of 3 milligrams per kilogram. This is his liver, okay, over here. There are some small gray spots that I'm sure are very difficult to see. But when the first time we did a CAT scan 12 weeks later, there were a lot more of these gray spots in the liver. And Tom taught me a very important lesson, which we all should remember as physicians and nurses, that always listen to your patient. They know their body better than you do. And he said, I don't know what those scans are going to show, but I feel better. And so I looked at those pictures, and I was like, well, you know, this is looking like the drug's not working. But the person in front of me says, I feel better. And so I took a harder look at things. I looked at some blood tests, and it looked like, well, maybe his immune system was getting activated. And so I said, you know what, Tom, let's just sit tight. And we did another scan 8 weeks later without any treatment, and most of that disease regressed, and it completely regressed 36 weeks later, and this was all 3.5 years ago, and his scans still look terrific. So this is the difference between immune therapy and many other types of cancer therapy. We're treating the patient, we're not treating the tumor. And so things may not shrink on schedule, and things may get worse before they get better, because we are asking the person's immune system to now, without breaks, go out there, see the cancer, recognize it, kill it. It may happen at different points in time, and some people faster than others. And so we have to have a very open mind as to when things are going to happen. We learned a lot from you. And so this is just October 2006 versus January 2010. I think you're due for a scan sometime soon also. I'm going to skip through this. But the most important data for a drug like ipilimumab is maybe not necessarily how many people's tumors shrink at a predefined point in time, like 12 weeks. Those are important endpoints that we've used in chemotherapy. But again, we're not treating the tumor, we're treating the patient. And so we need to take a much more global view of what the important endpoints are. And so in our studies with immunotherapy, we say, how long are people living, not how much smaller do the tumors look. And so with ipilimumab, this is the latest data that we have. There'll be more data presented at the ASCO, American Society of Clinical Oncology meeting in about 3 weeks from a big phase 3 trial. So keep your eyes and ears open from news from Chicago in about 3 weeks. But the latest data we have is highlighted in yellow there, which is the 2-year survival rate in people treated with ipilimumab after they had other therapy. And so having about a third of people alive 2 years or more with metastatic melanoma that has already gotten worse on other types of treatment, we think is a very significant figure. And we think this demonstrates the way that immunotherapy needs to be looked at. Not necessarily how many people have tumors shrink by a certain percent by a certain point in time, but rather how long are people living. Now, these drugs do have some side effects, as you might expect. Anything that fusses with the immune system may cause immune-related side effects. And so it wasn't surprising that we saw some side effects like rash and itching of the skin, inflammation of some organs like the intestines, colitis. My patients will tell you that nobody is more interested in their bowels than I am. Because if we treat these side effects early with prednisone, they are very, very minor. But if they get out of control, if people are shy about talking about the diarrhea that this drug sometimes causes, that's when people get into trouble. And so I think as more and more people get an opportunity to receive drugs like this, we have to appreciate that this is a new kind of side effect. And so the most important thing is to have good communication between doctors, nurses, and patients. There's no high science here. It's just good communication. And so one of the most satisfying things I'd like to share is that one of the first people who volunteered to be in an ipilimumab clinical trial was a young woman named Sharon Belvin, who got metastatic melanoma when she was 22 years old, developed disease in the brain, adrenal gland, and chest, and came as part of a trial to see us about 5 years ago, had a complete remission, and that remission was so good that she went on to have 2 babies. And so, we recognize that this drug does not help everybody, but it helps some people, and for some people this really makes the difference between having a life and not. Ipilimumab is one of many drugs that are now being looked at to try to modulate the way the immune system sees cancer. And as I outlined a few moments ago, it interferes with this molecule called CTLA4, which is important in breaking the immune system. But there are other antibodies that are being used to try to modulate the immune system in melanoma. There's an antibody to a molecule called 4-1BB, which has recently been in clinical trials. And more recently, and also at the ASCO meeting this year, there will be very interesting clinical results from antibodies that target a molecule called PD-1. And my analogy for PD-1 is it's the emergency brake on T cells. So PD-1 causes the immune cells called T cells to die on contact. And the trigger for PD-1, the handle that pulls the brake, if you will, is actually expressed on 100% of melanoma cells. And so if you were a melanoma cell and you wanted to protect yourself from immune attack, the best thing that you could do is to have PD-1's ligand or PD-1's trigger on your surface. Because what it's going to do, it's going to cause any immune cell that comes near you to die on impact. And so now we have antibodies that block this PD-1 molecule that are in clinical trials. Just a little bit more of a scientific description of that. And this was actually some data from Julie Bramer, a colleague from Johns Hopkins, who showed a regression in metastatic melanoma in the liver last year at the ASCO meeting with the use of an anti-PD-1 antibody. So in conclusion, we're learning more and more about how the immune system recognizes melanoma and other cancers. There are many drugs now that have been developed based upon these advances in basic science and leading to progress in immunology. The anti-CTLA4 antibodies are clearly the most advanced in terms of clinical testing. We hope that the phase 3 data will be available soon, allowing the CTLA4 blocking antibody ipilimumab to be available to everyone who needs it in melanoma. And I cannot stress enough how grateful we are to patients like Tom Telford and others who volunteer for clinical trials. We will never make progress. We can never make progress without clinical research. And without volunteers who do take a risk, we could never be where we are today. So thank you, Tom, and thank you to all of you for coming out today.